Good morning, everybody. It's my real pleasure to be here today to speak to a topic that's near and dear to my heart, actually. I applaud the Canadian Association of Police Boards for making mental health an issue and talking about this in an open and forthright way. Although we come at this from different perspectives, we have a lot in common, and hence I think there are many opportunities for us to collaborate together, and I'm hopeful that today, and based on meetings that I've had so far, that indeed will happen. I've been one of those people on the front lines, working for many years as a nurse in a hospital setting and in community settings as well. And I've also worked in forensic and corrections. So I've come across many of the same clientele that police officers come across and deal with on a daily basis. I know from experience that there are few more dangerous or stressful occupations than being a first responder. Whether you're rushing to the crime scene, reacting to a crisis, or doing triage in a standing room only emergency room, first responders are quite literally involved in life and death situations. Now, whether you're engaged in policing or healthcare, chances are high that you will encounter people with mental health problems in the course of daily work. It's not surprising, given that 1 in 5 people every year, that's about 1 in 3 in a lifetime, will experience a mental health problem or illness. And I'll talk about that in a little more detail in just a bit. Of those, there's a disproportionate percentage of people who get caught up in the justice system. And there are indicators that the prevalence of individuals with mental health issues is actually on the rise. For example, the rates of serious mental health problems among federal offenders upon admission have increased by 60 to 70% since 1997. According to Howard Sapers, the correctional investigator of Canada, roughly half of the people who are entering the federal system receive mental health services. So that gives you a fair indication of the numbers of people that police officers are coming across on a daily basis, and I know I'm speaking to the converted here. It is, however, very important to remember that people living with mental health problems and illnesses are more likely to be the victims of violence than perpetrators. Either way, whichever way you want to look at this, the statistics tell us that the worlds of policing and mental health intersect every single day. I want to outline how we can make this experience a more positive one for both police officers and the people that we serve. But most of all, I want to explain how members of police boards are an important part of this equation, and to highlight how we in the mental health field can work more effectively with you to create safer places. Now, what if I were to tell you that I know a way to improve on the many interactions police and people with mental illnesses have on a daily basis? What if I were to tell you that I know how to reduce the use of detention centers by the mentally ill homeless by up to 50%? And tell you that I know of a way to increase productivity in police operations by reducing absenteeism and making people more industrious when they are on the job, and cut short and long-term disability. Well, I actually can speak to those things, and that's what I want to do today. That's where the Mental Health Commission of Canada comes into. And I want to note that here with me today, we have another board member, along with the police boards. I have the Vice Chair of the Board of Directors of the Mental Health Commission, Dr. Fern Stockdale-Winder. Fern is here in Saskatchewan. She's coming to the end of her term with the Commission, unfortunately, but we're quite delighted that she's recently been appointed as the Mental Health Commissioner for Saskatchewan and is going on to take the work of the Mental Health Commission and apply it here in Saskatchewan in the development of a provincial mental health strategy. The Commission is a catalyst for improving the mental health system, and we are working very hard to change the attitudes and behaviors of people surrounding people with mental health problems. We bring together a number of leaders and organizations right across the country to accelerate these changes, and we've been working with police groups and others in the justice system now for several years. Thanks to this collaboration, the Commission's Mental Health and the Law Advisory Committee has produced a few evidence-based reports that provide new knowledge about how we can create positive change. Dr. Terry Coleman, who many of you know, has been on that committee and is the author of a couple of reports that I'm going to be speaking to here this morning. We've produced, for example, a study of police academy training and education for new police officers. It looked specifically at working with people with mental illness. The first report did an analysis of the amount and type of education provided to police officers across the country. And the second includes several important and relevant recommendations specifically addressing training and education. No matter what part of the country you represent, the study's results will be of value to you. Among its findings, it's noted that larger police forces, like Vancouver, report up to 1/3 of their calls in some of their jurisdictions involve mentally ill people. In smaller communities, such as Belleville, Ontario, at least 6% of police resources and time are tied up in cases involving people with mental illness. And generally, police encounters with these individuals happen more than one time. Even using the lower Belleville number, and assuming about half of Canada's police officers are frontline or first responders, that equates to approximately 1.3 million interactions between police officers and people with mental illnesses every year. That's a pretty persuasive case for ensuring police officers are properly trained to deal with this population. And the report goes on to say that although there's been an increase in training and education in recent years, there's no commonly accepted standard or curriculum. In the report, Police Interactions with People with a Mental Illness, which is found on the Commission's website, I want to make mention of a few key points within that report. Firstly, is that while it's widely recognized that increased and better education is needed, it is not a panacea. It has to be tempered with contextual factors such as organizational structures, social systems, who should be taught, by whom, and complementary policies that will support it. In other words, overall cultural considerations, both within the particular organization as well as the community at large. The report goes on to outline a detailed learning model called TEMPO, which stands for Training and Education About Mental Illness for Police Officers. It starts with TEMPO 101, and this is basic training. And it goes all the way to TEMPO 401, an advanced learning curriculum for joint police and mental health teams, and even TEMPO 500, which is a learning module to be inserted into use of force training. In other words, it's extremely, extremely important that this critical step be included in any physical contact before it's ever even contemplated. The goal of this step is that we should always be looking at ways to de-escalate a situation before any kind of force is used. And I know that this, in discussions I've already had here since I've arrived in Saskatoon, that this is an issue that many police chiefs are quite concerned about and are very interested in. I also want to tell you that a revision is currently underway, and that Drs. Coleman and Cotton are going to have this completed by March, where we will have a new State of Police Learning report ready for you. And so we are actively engaged and quite interested at the Commission in looking at this important issue. We actually welcome every opportunity to partner with people working at the community level who can really make a difference. And in fact, we're also collaborating with the Canadian Association of Police Chiefs, and we're going to be working with them side by side for the national conference that's going to take place in March of 2014, where we will be able to build on the progress that I know we're going to make here as a result of this conference. Excuse me. As identified in the Tempo report, there are many tools and ways in which to address mental health education. One of the many helpful tools that the Commission has developed to advance its work is called mental health first aid. Now, many of us have taken first aid courses where we learn how to stop the bleeding if somebody cuts themselves in order to give us time to get them for help. So in the same way, mental health first aid doesn't teach people to be therapists, but it helps us to identify the signs and symptoms and then what to do long enough to get people for help. I've heard many times that, gee, if only I had known that this was a symptom or a sign of a mental health problem, I would have done something about it. I've also heard people say, I knew it was a problem, but I didn't know what to do. And this is a very basic course that allows people to be exposed and have a conversation about mental health problems and illnesses. We've recently begun providing this course to first responders in fire departments, and I've heard it said by them that, gee, this is the first time we've actually sat around and had a discussion about this. And so it is an opportunity to provide education in a cross-section of settings. It can also be, it goes from psychological health and safety in the workplace to schools and community groups to working with homeless people on inner city streets. So it has a broad application. We've been promoting this course for first responders, but it's also available to the general public, and several police departments across the country now have mental health first aid instructors on their staff because it is a train-the-trainer concept. Apart from being better equipped to address mental health problems and illnesses in people that serve day to day, police officers report it's equally valuable in recognizing the signs of emerging mental health illnesses amongst one another. Now, this is a very interesting concept, and one that I will get to shortly because it's a very important topic. But first, I want to touch on one specific population that police officers are very likely to encounter on their job, and that is the population of our homeless Canadians. The homeless experience high rates of mental illness, much more than in the general population. 25 to 50% of people who live on the streets experience some kind of mental health disorder. While their individual mental health challenges and personal circumstances vary dramatically, the common thread that ties most of these people together is simply that they do not have a roof over their heads. I was speaking with a reporter in the last day or so who said, what on earth does housing have to do with mental health and policing? And it is, and again, I think I'm speaking to the converted, an extremely important topic, and one that impacts each and every officer that is currently functioning. Despite our social security system, there's an estimated 150 to 300,000 people who are homeless in Canada today. And this ends up costing us about $7 billion every year in increased health care, justice, and social services. On any given night in Canada, at least 30,000 people are sleeping outside or in temporary housing in places like prisons and hospitals. And this costs anywhere from $163 to $975 a night. As hard as it may be for those of us who are comfortably middle class to believe, some people are so desperate for shelter that they purposefully provoke situations that bring them in contact with police. We've heard this frequently as part of the Commission's At Home Chez Soi initiative. This is the largest research demonstration project in the world on homelessness and the mentally ill. Back in 2008, the federal government provided us with $110 million for a 5-year demonstration project. And that data collection is now completed. And we have an interim report, which I'll tell you a couple of interesting statistics from. And in the new year of 2014, we'll be delivering the final report. This is something that is long awaited across the country as well as internationally. Many other countries are experiencing the same issues and are extremely interested in learning about the findings from At Home Chez Soi. At Home Chez Soi is taking place in 5 cities across the country: Montreal, Moncton, Toronto, Winnipeg, and Vancouver. And the initiative takes a very novel approach to helping homeless. Instead of starting with treatment and getting people healthy enough to cope with living on their own, this is a housing first, and it's quite literally what it means. We provide housing without any strings attached. Back when I was nursing, many years ago, we spent a great deal of time trying to get people ready for the community. They had to be so-called stable. They had not to be using. All of these criteria had to be met before they were given any kind of housing. And yet we wondered why there was a revolving door, why people kept coming back in. And very often they came back in accompanied by police. Close to 1,000 people with mental illness have been provided housing and services as a result of this project so far. The early results, as I mentioned, have been truly remarkable. This research gives both individuals and communities real hope for an effective and cost savings alternative. And we're already working with several cities, Saskatoon included, in terms of trying to implement a Housing First program. The reality is that homeless people with mental health problems can maintain housing. We were told at the beginning of this that this is not going to work. I mean, you're talking about people with very severe and chronic mental illnesses. Who are you going to find to rent, that will rent apartments to people? And you know, they won't stay in them. Well, the good news is that we now know that a large percentage of the people that were placed originally are in the same homes that they were first in. It can dramatically change lives. And a couple of summers in a row, I've actually visited people in their homes, and it's been a very humbling experience. This can also serve, as you know, to significantly reduce the number of interactions between the mentally ill and police officers. So while it's important, and I know that the focus and a large amount of attention is being placed this last few weeks on the kind and amount of training provided to police officers in dealing with people with mental illness, it's very important that in looking at this issue, what we're trying to do is actually prevent those interactions from happening in the first place. And housing, adequate housing and supports, is a way of doing that. We've shown already in this study that the people that were in the research program as opposed to the treatment as usual, that after 2 years they are using detention centers and emergency rooms 50% less than the treatment as usual. That's 50. So when you look at that, that's a large number of police interactions that are not having to take place. Housing First is also about spending smart. The cost of shelters and increased health services use far outweigh the price of providing the mentally ill person with a place to live. Our findings, just to quote a couple of numbers, is that on everybody, that on every $10 that there's a savings of $7 on every $10 that's spent. But the really good news is that for those who are the highest users of shelters and correctional services, that $22 was saved on every $10 spent. So there's also a strong economic argument for looking at housing, as well as a safety issue in terms of policing. At Home Chez Soi really helped to inform Canada's mental health strategy. And up to about a year and a half ago, we were the only G8 country that didn't have a mental health strategy. So we are delighted and very proud to have a very comprehensive one. The strategy tackles a broad range of issues affecting the entire socioeconomic spectrum. And we know that there are some 7 million Canadians, approximately 20%, live with mental illness. Now, I'm going to be talking about stigma in just a moment and workplace. But when I want to put this in perspective, because the numbers in and of themselves really don't mean very much. So we have 20% of Canadians suffering from a mental illness. We have 7 million people living with mental illness in comparison to 2.2 million living with type 2 diabetes. And then on top of that, how many of us here don't know of somebody who has suffered from heart disease of some kind? Well, 1.4 million are living with heart disease. Now, if that 1.4 million of heart disease suddenly turned into the 7 million that are suffering with mental illness, I think we'd be talking about we have a crisis in situation here. But because it's mental illness, we seem to complacently sit back and accept it. I don't think it would be the same situation if we're talking about heart disease and cardiac problems. Now, I also want to talk about the fact that this morning in Canada, 500,000 people called in sick due to a mental health problem. Every single day, that's what happens here. Several of those people were police officers. So, and now more than ever, I think that we have to redefine what the workplace is. I want to talk about the mental health of police officers. That isn't something that we've been hearing a whole lot about. Yes, we need to look at the training and education for how to interact with people with mental illness. But the more mentally healthy all of us are, including police officers, the better equipped and the better able they are going to be to respond to situations. The workplace, once upon a time, was somewhere you went at 9 o'clock and left at 5 in the afternoon. But now, We're looking at the fact that it isn't a place or a building. For police officers, it's streets, it's northern communities, it's rural settings. And the mental health strategy for Canada really places a premium on workplace mental health. It's where we spend most of our waking hours, is in the workplace. We have occupational health and safety standards. All of us are familiar with those. But yet, the psychological part of it isn't a big component. So we know that Canadian workplaces need to do more to support people experiencing psychological problems on the job, and police officers are no exception to this. They require everything from mental health promotion, illness prevention, to anti-stigma initiatives, and especially anti-stigma. Mental illness continues to be fraught with discrimination right across the board. In a profession like policing, with its rugged, tough guy image, it may be even worse. I know a young woman very well who became a police officer just a few years ago. And in speaking with her, she was telling me about the first time that she was called to go to a scene, which was an abandoned car, and it was in the middle of the night and she was by herself. And unfortunately, it was the scene of a suicide. And she said to me, she said, when I looked in the car and opened the door, she said this woman's face looked like a Halloween mask. And it is the image that she saw for a very long time afterwards in her dreams. And it's the image she still cannot get out of her mind. I know this is just one out of perhaps hundreds of thousands, if not millions, of images that police officers encounter on a daily basis. Now, I've worked predominantly in healthcare, and I can assure you that if that had happened in a healthcare setting, that nurse, physician, social worker, whatever the case may be, had come upon that scene, there would have been tremendous amount of debriefing. There would have been all kinds of supports provided. That didn't happen for this young 27-year-old woman. And so I suspect that her ability to be able to respond well to situations thereafter were impacted by that. This is where police share challenges that we hear about more frequently in the armed forces. Senator Romeo Dallaire talks about how it would have been easier for him after returning from Rwanda if he'd been missing a limb. He would have received sympathy and understanding. But suffering from post-traumatic stress disorder wasn't something he could talk about openly. An injured brain simply doesn't have the same impact. One of the groups that the Commission has targeted for its anti-stigma program are healthcare providers. Now that's a sad statement for me to have to make. I'm a registered nurse, and here I am working with a group that has to target healthcare providers because we're seen as barriers to people getting mental health assistance. It's safe to say that if healthcare professionals view people with mental health problems negatively, that it exists amongst police officers. The biggest obstacle to getting help for people is the fear of ridicule and rejection. However, avoiding treatment workers' need comes at a very high price for police boards, healthcare boards, employers in general. Those who go without support experience higher rates of absenteeism and what we call presenteeism, which means you're showing up to work, but you're not performing to the highest of your ability because of dealing with a mental health issue. And so therefore people are far less productive, and there's a higher turnover of staff. Some 30% of short and long-term disability claims in Canada are attributed to mental health problems and illnesses, which equates to costing Canada every year approximately $51 billion. I've had people say to me, we can't afford programs to deal with this. My response is, we can't afford not to. These costs are escalating, they're almost growing exponentially, and if we don't deal with them, they're going to continue to grow. So we need to openly discuss these issues, because if we were to triple the amount of health care budget we currently have, which isn't going to happen, if people are too ashamed, embarrassed, and afraid to go for help, even if they're there, it isn't going to help. I'm the CEO of the Mental Health Commission of Canada, and in the last couple of years, I had two colleagues of mine, who were in mental health, by the way, come to me and tell me, one of them who suffers from depression from time to time, and another one with bipolar disorder. After they talked to me about this, one of them actually called me up the next day and wanted reassurance that I didn't see her any differently than I did before. And so, yeah, I mean, if that's happening in my situation, then I think it goes to speak to what is happening outside of the mental health situation. The Commission has recently led the development of a voluntary national standard called for psychological health and safety in the workplace. The standard provides guidelines that enable employers to create and continuously improve psychological health and safety for their workers. We also have an action guide, which is on our website, which is an excellent document. And among other things, it helps employers to assess workplace hazards, such as stressors from job demands, provides advice on how to help employees address them. Our hope is that all employers, especially Canada's police boards, given the challenges that your workers are facing on a daily basis, will adopt the standard. You'd be joining good company, by the way. Since its launch in January, the standard has been taken up by hospitals, universities, law firms, corporations, and the public sector right across Canada, and it was only released in January. Both Bell Canada and the Government of Canada have pilot projects underway, and we have 2 provincial governments who are about to implement it. We've also partnered with the RCMP and the Maritimes that are testing a program called Opening Minds for the Commission's Anti-Stigma Initiative. And the Commission would be absolutely delighted to initiate a partnership with the Canadian Association of Police Boards on any of these initiatives. Now, when I talk about the standard, people say, what is this about? Tell us what's involved, because it sounds like it's a bit overwhelming. And there are very specific approaches to it, and it's meant to be done in bite-size components, so smaller pilot projects. But we've developed a very short video clip that outlines the steps that would be involved in implementing the standard. It's just 2 or 3 minutes, and I'm going to show it to you here right now because I think it outlines better than my description would be of it. So hopefully technology will work, and look at that.
1 in 5 Canadians will experience a mental health problem or illness each year. When we're not well, it affects everything we do, at home and at work. And most adults spend more waking hours at work than anywhere else. It's why workplaces should care about mental health. The cost of mental illnesses to the Canadian economy is at least $50 billion per year. That's 2.8% of our GDP. In any given week, 500,000 employed Canadians are unable to work due to a mental illness. We need to turn this around. Positive mental health benefits all Canadians. It sustains our families and communities, keeping employees healthy, productive, and at work. We can help make it happen. The first step? access the National Standard for Psychological Health and Safety in the Workplace. This voluntary standard takes a complex subject and makes it easier for employers to create a mentally healthier workplace. It's the first of its kind in the world. Here's what your organization can do right now. Review the standard and commit to it. Identify a workplace champion to take responsibility for your commitment. Identify gaps in your organization. Actively involve employees in the process. Use the tools in the standard. They will help prevent mental injury, reduce psychological risk, and promote good mental health in the workplace. Develop a policy statement around workplace psychological health and safety. Take the time to communicate what this commitment means to all employees. Use other tools available, including the Mental Health Commission of Canada's Action Guide for Employers, and have your staff trained in mental health first aid. Commit to good mental health and contribute to the economic prosperity of the country. Lead the way. Start today. Visit us at www.mentalhealthcommission.ca.
So all we need to follow up on this is your consent, but more importantly, your leadership. There's so much more that I could talk about today. I think you've probably gathered that I'm pretty passionate about these issues, and we want to be able to assist. And so I think that, while it would be nice to walk away from this conference and say, well, gee, that was interesting and that was nice and it was pleasant and everything, what we really want is there to be follow-up action items. And so I'm presenting two opportunities to you. And one is with regard to the report on tempo in terms of the curriculum for police officers dealing with the mentally ill. And we'd be more than happy to discuss how we could go about doing that. Terry Coleman is very happy to join us in potentially looking at a pilot. And the other one is workplace mental health. We're concerned about the mental health of everybody in Canada, and we're certainly concerned about the mental health of the people who keep our streets safe every day, our police officers. And so with that, I'm hoping that we'll continue, and quite optimistic that we'll continue these discussions. And I'm not sure if we have time for questions or discussion, but I'm certainly available now or at the close of this session. I thank you very much. I applaud you for making mental health an issue, and I look forward to further deliberation. Thank you.